sir, start please.
Good morning, everyone. It's a pleasure that today we have Dr. G.D. Puri, Professor Dr. G.D. Puri from the Postgraduate Institute of Chandigarh, and he is on the forefront of the battle with COVID-19, and I would say he is the commander of the regiment of Corona warriors. So first of all, I think we should have a huge thank you for him for devoting such a lot of his life fighting this virus. And the idea came to us that it will be a good idea if we could share his experience, because he's seen things that most of us are not even aware of. And of course, looking at his complete commitment to the cause and looking at his devotion and dedication, even in the face of personal risk. And
We cannot hear you actually in between your voice cuts.
Madam, I'm not able to see that Deepthi, I'm not able to hear very clearly.
okay,
We cannot hear clearly actually. Ma'am, we could not hear clearly. Can you hear me clearly? Could be that your Wi-Fi, the network is fluctuating.
why
Ma'am,
don't you
I
Sonia and
welcome
become
sir formally.
yeah. Maybe there's
Yes,
some
ma'am.
connection.
Good morning, everyone, and welcome to the. Yes, and I'll not switch on my camera because then it is easier to connect. Okay. Good morning and welcome everyone to today's webinar. And it is my honor to introduce, though sir does not need any introduction, still I'll formally welcome and introduce Dr. Puri to everyone. Dr. G.D. Puri is Professor and Head Department of Anaesthesiology and Intensive Care at Postgraduate Institute of Medical Education and Research, and has been working as faculty in Department of Anesthesia and Intensive Care at PGI since 1986. That's around 34 years. He is also Chairman, Advanced Cardiac Center, Dean Academic at PGI. Sir is also Chairman, Biomedical Instrumentation and Devices Hub. It's a Center for Innovation, Design and Clinical Validation. He's a well-known cardiothoracic anesthesiologist in India, and I want to tell everyone that Sir and his team have been working all through the COVID-19 lockdown. Sir, we respect your 24/7 commitment to patients and his deed for your profession. We are grateful that you have taken out time for us today and welcome you in today's session. Welcome, sir. Over to you, sir. Ma'am, sir. Dr. Puri, please switch on your camera and we can.
Hello,
Yes, sir.
can you hear me, please? Hello.
Yeah, yes.
Okay. Good morning, Dr. Deepti and the team from Punjab University, and I thank you, the VC Saab and his team, for giving me opportunity to share this my experience in this pandemic, and how the PGI team carried out this battle with the COVID-19, or I should say, we have tried to do create a scenario where we can live with it and keep doing our work and rest of the work which we are supposed to be doing.
Please talk loudly.
Hello, am I audible, please?
Yeah, please talk.
You'll have to be louder, Dr. Puri. Maybe you can bring your mic closer.
What about now?
Better, better.
No, is it very good or better only?
It's good now.
Okay. So once again, thank you to the Punjab University team for giving the opportunity to share our experience. And I will try to just go through this our team's efforts in managing the show while the COVID-19 pandemic was, declared in the first week of towards the first week of March, and at that point of time, the scenario was that people were thinking it is going to come, it's going to come for a few months, it's going to be over, and as all of you know, it started all in Wuhan towards the end of November, beginning of December. Who started it, how it started, we are not here to discuss that. But then people still thought at that point of time that it will restrict to that area, or they will be able to restrict within their country also. But unfortunately, from the mid-February, it started showing in the Europe, then at the end of February in USA, and the situation was that in the first week, at the end of the February, you could see such horrifying images from countries like Italy, where they were mobilizing beds. There was shortage of doctors, there was shortage of hospital beds, and the country like US had run out of the beds in the first week of March. So one can imagine the situation, how much we were prepared, what was the extent of this the disease or pandemic. And you could see within a couple of weeks, the streets were, the airports were closed, or the minimum flights, and the streets were empty. People were, stick to their houses. And at this point of time, the middle of March, when the government really got active, they were working on it since January, but the real thirst came in the middle of March, when they started thinking that if the rate at which it is growing, and is growing in India, whether it came from outside through the flights or people coming, they were, that foreign travelers missed at the airport, transmitted to the other people in their localities, whatever the cause. The fear was that the way it is going up and the way it has happened in Italy, it can, the people are thinking that maybe we will be able to compete with Korea, we'll work like Korea, not like Italy, and we'll be able to flatten the curve, we'll be able to restrict the entry of the virus. And the other people thought that maybe it's summer time, the virus will not stay long, and we people are very, we have a history of tuberculosis, we have a BCG vaccine, we have lots of, local, spices or whatever the people thought of, that it's going to restrict the entry of this virus, and of the severity of the disease is going to be less than what the other countries are. And at that point of time, the people, when the whatever we had thought, it started going the other way, then the people were projecting the number of patients may go up to 9 lakh towards the end of May. And if the number of availability of beds, even if we say 20% or 10% of these patients may require hospitalization or ICU beds, then that even those are in at the present availability of beds at that point of time, number of doctors and healthcare workers was so less that it won't be able to cope up with. So then the people started thinking that whichever state has better number of beds, more number of beds, they may fare better than those who did not have as much beds. So there was the thrust from the government was to build up the capacity of the hospital beds, the quarantine beds, the ICU beds, but we had a limitation that something which we didn't do for many years cannot be done overnight. So if a country like US can struggle with this situation, with the ICU beds, with the ventilators, and if we come at the bottom of this list with the top at the United States with the maximum number of critical beds per capita. So not only these ICU beds, we were confronted with lack of PPE or the personal protective equipment for the healthcare workers. Not only for the healthcare workers, for the general public, the masks were deficient, the sanitizers were deficient, everything disappeared from the market. And then we started seeing such pictures on the TV reminding us what happened 100 years ago with the Spanish flu and how they were managed in the community or in the hospital. So when we cannot solve our problems with the same thinking with which we created, then we have to think differently to counter those problems. So one of the thought at that time, which was probably the best thought, was, can we somehow, this peak which is growing up, can we decrease the rate of peak? And can we decrease the peak? Can we decrease the rate at which is coming? So these were the three, the major things which was conceptualized, that staying at home, wearing mask, keeping distance if you're going out, and hand hygiene. These are the things which will be able to decrease decrease the number of cases, or maybe delay the cases coming up in the community, and maybe that by that time the people or the country will have time to pull up the socks, build up resources, and maybe the time when we open up and the number increase, we have the capacity to fight this disease. So the same, the PGI was given the task of setting up a dedicated corona hospital in addition to the other hospitals in the city. The major task was given to the PGI, and PGI, as you know, a place where every day more than 10,000 patients visit the hospital, and more than 20 to 30,000 attendants also come along with that, and the number of admissions every day are couple of hundreds, and every day couple of hundred surgeries are being done. So this was a big task, that in this situation, can we maintain distance? Can we maintain high hand hygiene? Can we prevent the transmission of infection from one to other? So the first thing which the PGI did was to stop the routine OPDs while the emergency kept on going. So this was towards the 22nd of March. We stopped the emergency, we stopped the OPDs, we stopped the routine operating rooms, so that whatever the personal protective equipment we have, whatever mask we have, whatever the sanitizer we have, whatever the other logistics disposables we have for the patient care or intensive care, we should not exhaust them and try to build the stocks of the hospital like any other the hospital was trying to do. So, but at the same time, we were thinking how to create this extra beds which the administration had asked us to develop, around 200 beds. And the COVID hospital is not a simple hospital where you just have the beds, you have the space, you have the washrooms, and you provide the simple drugs, and everything is done. There are specific requirements for this hospital where the disease is transmittable quickly from one to other, and the mortality and morbidity is quite high. So we had to think a lot how to. Fortunately for us, we had. Hello, am I visible? Hello.
Sir, your slide is visible and we can hear you clearly.
I think something I did some.
We can hear you loud and clear. Don't worry.
Okay, and you can. Hello.
But we can't see you. We can see
Can you
your
see me?
slides.
I have stopped. I think I did. Okay. Yes. So thank you. It has to be a teamwork. No one person or one specialty or one group of people can do it. So the first thing was, can we build a team quickly to achieve what we were told to achieve? So we had our administration headed by our director. We had our medical superintendent, deputy director. They all helped by. I was given the task of setting up the NHE hospital, which was earlier being used by the hepatology department, by ENT department, by the oncology department. They had not fully shifted at that point of time. They had only shifted their patients. 50% of their staff was working in that hospital. So what we thought, that first we shift those patients into our main hospital, as we had cut down our admissions, as we have cut down our surgery. So the number of beds we can vacate from the main hospital, shift them there, and then take this hospital as a dedicated, isolated hospital for doing the COVID care work. So we had we made a multidisciplinary team. Our aim was to identify the different parts of the hospital which could be used for different purpose, and installation of equipment which is required for the carrying out this work, critical care work, taking care of the COVID patients, and the people who are going to work. Their training and safety was the most important. The moment we tell somebody that you have to go and work in the COVID block, people were afraid. So that was a major challenge for us, to how to motivate those. So what we thought, that we have to be on the forefront. So that was the reason we, the different team leaders, we always remained at the forefront, because if we try to go back, then our the staff is not going to carry on the work which they were assigned. So we set up the ICU there. We made a team of multidisciplinary team of intensivists, physician, pulmonologists, anesthesiologists, infection control specialists, hospital administration. The space was identified, but we within that hospital, we identified where we will create an ICU, where we'll create a ward, where we'll keep the less sick patient, where we'll try those patients before we take in, how the patient's movement is going to be there, how the staff movement is going to be there, where because it is not a simple hospital where even in other hospital you are exposed to the infection, but it is still preventable and the morbidity is not that high. But if you get this, as far the knowledge was available at that time, people were afraid of going into that place. So we isolated the patient care areas from the rest of the area. So this was the building. We had different blocks and we identified that the ground floor is not going to be it's going to be clean area except the place where the patients are going to be enter. This was the main entrance of this. So top floor we put up the ICUs, we had the the operating rooms, the A1 and A2 blocks, and because some of the COVID patients may be having a requirement of surgery, so we set up an ICU, the operating room here with special facilities for taking care of COVID patients, along with the other non-COVID incidental surgery. So we made the reception at the ground level. This was the entry place for the patients. From this side, the patients will come. They go to an elevator which was dedicated for that the infected patients or the patients or the people who are with full personal protective equipment geared up. They can go from this side. Not as other. This is the clean area where anybody will be who is working at the ground level can come, and or he can come before he is dressed up with the proper dress to go up. So we had the staff which were going to work in the infected area. They will enter from the back side. It's a semi-clean area. They will put up their PPE, and after putting up the PPE, they have a dedicated lift which will take them to the second, third floor, fourth floor where the patients were to be housed. And then there were clean supplies elevators where only like if you're going to send the food, if somebody is going to take some equipment, new equipment, we'll put that into the elevator. Elevator will go at the top. The healthcare worker will just take that equipment or the food and put it outside the lift, and the lift will come back. So this lift will remain the clean lift. So that was the plan which we made, and we had 200 beds. We had 2 operating rooms which we activated, though we had 10 operating rooms. And sorry, just let me. Sorry, I forgot to switch off my phone. So we had a pediatric unit. We made a pediatric unit on the second floor. We had the intensive care unit on the top floor. We had about 200 beds, 2 operating rooms. And another thing which we had the issue was air conditioning. This area was built up for not COVID. In COVID or most infected patients, you need to have non-recirculating air conditioning, negative pressure rooms. Unfortunately, we didn't have any negative pressure rooms, so we had to create within a short span of couple of days how to do that. So what we did was we discussed with the engineers what was the best possible solution. We stopped the recirculating, closed the recirculating ducts. We put up extra exhaust fans, and we put our AC at the full blast. That did decrease the efficiency of the air conditioning, but we were the safe as far as the recirculation of the virus was concerned. And we told them that in the private wards or other wards that keep the windows open so that the fresh air can come, or that the breath which was exhaled by the patients is not rebreathed by the other non-infected patient, the healthcare workers which were present. We had we needed to mobilize the ICU beds, we mobilize the monitors, we mobilize the ventilators, all equipment we mobilized from the other parts of the hospital. As the work had decreased, we had decreased the work in our other areas. So we mobilized our echo machines, we mobilized our ultrasound machines, so ECG machine. We tried to mobilize whatever we could from the rest of the, because it was not so easy to quickly purchase from across the window. The reason was the lockdown had started and everybody was trying to buy whatever was available in the market. The cost of the ventilators had suddenly doubled. The cost of any equipment had increased. The availability had decreased. The personal protective equipment, the cost had gone up. The availability was not there. So we had a lot of difficulty in that period of time, especially when we had the whole thing was locked down. Nobody could just move across. So the biggest challenge was the PPE arrangement, procurement. Is it good quality? Is it satisfying the healthcare workers? Then special equipment like intubation box, etc. We had to, make locally also. Some of the things we made locally. So these were the protective shields which we got made from the local TBRL organization. We made some local manufacturer helped us in making these boxes, and then there was controversy started. Which type of mask is good, which is not good for the healthcare workers? As usual, there is when there is a deficiency of a high quality mask or high quality equipment, and you try to substitute with next quality, they are going to be eyebrows are going to be raised, people are going to not happy. But we had to use whatever was available with us within the constraints of, not only the money was not the major constraint was availability of the equipment. And then we had to deal with these sort of issues when the employees or the workers will go to the press, and the administration got the beating. But I think that was a good thing, that we got the feedback. We tried to convince the people. We tried to do the best available. We made the committees to look after each of this. In addition to the NHE management committee, NHE is a Nehru Hospital Extension block, which is a COVID block. In addition to our management committee of that, we made a staff deployment committee. We made a staff welfare committee who look after the food, the stay, as well as the transport of the healthcare workers during that lockdown period, and especially those people who are working the COVID block. We made training committee who will train the various the healthcare workers, not only for what are they going to regarding the treatment of the patient, but more was how they should be dressed, their protective equipment, how they will ensure that there is they do not contaminate themselves, how they should they work with that personal protective equipment in that isolated remote environment where the amount of support will not be that great as in the main hospital. So there were training sessions were held, and the PP committee had the maximum work because they had to not only check for availability of the various the masks, the gowns, the gloves, but also the quality of that. Then the lab committee to ensure that the lab works 24 hours for the care of not only the main hospital, but also for the COVID block. And the people who are working, the lab attendants, the lab technicians, the doctors, they were afraid of handling the specimens. So giving the protective equipment, making sure that the samples are transmitted without a spillage, and they had rooms where they could open up, and it was sterile. It was room which specific biosafety measures were employed in that rooms, or the specific small cabins. So we had to involve all sorts of staff when we are making a committee. It's not only the doctors, the nursing staff, the healthcare, the hospital attendant staff, the nurses, the safai walas, the lab technicians, everybody has to be on the same platform if we have to work and produce good result. Now, people were taught how to wear the mask properly, not like the way people were using, and how to do the fit test of these masks before they wear. And at the same time, different people will have different face shape, and some masks will fit better to one type of stature of the patients. The healthcare workers. Some will have beard, and they were asked to trim the beard or minimize that, because then otherwise the fitness the mask will not fit properly, and it will leak, and if it leaks, then you will be inhaling the infected air. So a lot of efforts we need to put in to train our healthcare workers, make sure that they don't put the hands on the outside of the mask, which will usually be infected, because when it is filtering the virus or any other bacteria, it will stick to the outside of the mask. So making sure they don't put hands on those masks. At the same time, making sure that if they touch, they clean their hands immediately after that with sanitizer. And while removing the mask, they have to be taking special care not to touch the potentially infected surface of the mask. Similarly, any gown or gloves which they wear, they have to make sure that this is not they don't touch the infected part of that equipment or the wear. So make sure that they do not carry these masks home, because that will spread the infection to the homes. So how the proper disposal of these masks is, that was also taught to each of these things. There are videos available online which can teach you how to wear the mask properly. And so at that point of time, as I said, the PPE, the availability was insufficient. The proper quality was not available. So we had a lot of work for the PPE committee. And see, this is the area. This is a donning area where the healthcare worker has to put on all the protective gears like gown, overall, the cap, mask, and there are people who are going to help them in putting up. They have put it's just like a backstage fashion area. You have to go on the ramp, and before that somebody is making sure that your mask is properly fitting, your the gown is properly covering yourself. And before all this happening, a day or couple of days prior, they were taught how to use this this PPE. Like here, as I said, as I shown that you have a healthcare worker teaching another healthcare worker how to wear all these things. And then we made put the CCTVs in the area where they were to remove their personal protective equipment after they have done their duties. That was another dangerous area, because when they have taken care of the patients, their gowns, their gloves, there may be virus everywhere on the outer part of their the clothes. So when they take off those clothes, we have to make sure that they do not touch the dirty area. So they were taught how to remove all this personal protect PPE. And but we trained our nursing college staff to do the duty round the clock, because they were the healthcare workers will be on 6 hours duty, so they will be coming at odd hours. So somebody has to make sure they don't mess up with their putting on of the PPE as well as putting off of the PPE. So we put the CCTVs at all the doffing areas, and these ladies were watching around the clock. And they were even guiding those people through the two-way mic system to help them what is to be done first, how they have to do the thing. And in addition, we had fortunately in that building there were some CCTVs on the different corridors. And what we did was somebody was monitoring that no unwanted person just by mistake step onto those dirty corridors, so that he may not be exposed to the infection. In addition, what we did in this in our ICU there was that only the so that the expert is able to take a stock of the situation. We put the CCTV in each ICU near each bed, so that even if the senior doctor doesn't go up into the ward or ICU, he can see what's happening. He can guide his junior colleagues. It was not that they were not going. There was a one faculty on each floor, sometimes two faculty on each floor, who will go 2-3 times in a day, take rounds of the patients. But there were residents who were working all the time. They were working, not only the residents, but the nursing staff, the healthcare worker, they were working. And we could monitor their working from sitting in our control room. We could guide them. And because of that, this CCTV, we were able to, I shouldn't be saying that we were able to keep tab of what was happening, but we were able to take care of these. In addition to that, as I told, we had CCTVs in the corridors where the security personnel were constantly watching for unknown person stepping into a wrong place. And similarly, when the patients were shifted from other hospital or from the emergency area of PGI, they had to follow a specific path. So we made sure that the patients and those healthcare workers who were accompanying those patients, and they might not have come to this area earlier, they could be guided through the CCTV and two-way communication. Then we put up the remote monitoring, not only the CCTV, but also remote monitoring. We put up the monitors which were they were hooked to the Wi-Fi, and all the blood pressure, heart rate, and other parameters we could not only access remotely on our computer, but also on our Android or iPhones. And so we could keep a round the clock tap on what's happening, and if we can help them to detect any abnormality and take the necessary action quickly. We set up that operation theater there. You just imagine in that area they had to, where the visibility is decreased. When we were putting the protective equipment, if you don't put up the protective equipment, you will put yourself onto the risk of getting infection. But if you put it, your visibility decreases. So it was very difficult to work in that environment. But our surgeons, our healthcare workers, they did the job very efficiently. And until now, in there we had almost 40 cases. This is the data about 3 days back. So about 40 cases we have, surgical cases, head injury cases, abdominal surgery cases, so many cases, and cesarean babies delivered there. So we were able to do in the COVID block. Now, the orientation was the major the time when we needed to do the moral boosting of that healthcare workers, because what was happening, nobody wanted to work permanently. So we made a roster, 7 days roster. They will work for 7 days before they will get a training, and then they will be oriented that which area they are going to work, what type of challenges they will have to face, and how to overcome that. We had the mentors for each area. Like if there's ICU, we had control room faculty, we had training faculty, traders faculty. And then after they are trained, they work, they will quarantine for 7 days. So they will put up an isolation. That there was fear that if they go back, and if they are by chance infected, they will infect their families, their children. So that was the reason they were made to isolate during their duty period, but also for 7 days. And when after the 7 days, they were usually tested before they were allowed to go back. And they have our healthcare personal welfare policy was that make sure we check anybody who's being posted there. They should not have any comorbidities. They were not, age was, we check the age. And once they were inside at the time of work, or when they were even in the hotel or the guest house where they were staying in the off duty period, somebody was always there to keep in touch, understand their problems, try to solve those problems. And every day they are asked that if there is any breach in their personal protective equipment, if they were by mistake, they had to, the mask got dislodged. There were instances when suddenly the nursing staff, or even in some state the other healthcare workers, they felt dizzy, they felt nausea, and they immediately removed their mask and gowns, and that resulted in the breach. So we isolated those such cases, and we quarantined them, did not let them work later on, and then tested that. Fortunately, none of these patients, they were found to be positive. So somebody was taking care of the accommodation, somebody was taking care of the transport, somebody was talking to their family, somebody was talking to the kitchen so that they get the proper food. So we had, as I said, we had training of infection control people, we had training of donning, doffing, we had training of working on the patient, what critical care management they have to do, making sure that while they are doing taking care of the patient's breath, which is when the patient breathe, or when you do put an endotracheal tube the unconscious patient, it is an aerosol generating procedure, and that can lead on to generation of lot of micro droplets. So, and if you inhale, and the chances are you will get infected. So making sure we train them how to avoid infection from the patient. So it was really a team which was looking after this. This healthcare welfare team was being looked after by Dr. Usha, and then Agarwal was looking after the hospital attendants, and how they were motivated after how they were trained for taking care of patient as well as themselves. So that's about the healthcare worker. But what we have, this disease was totally new disease. And even though 4 or 5 months have passed, but the people were not very sure what is the cause of morbidity, what is the cause of mortality, which drug will be able to treat. Even now, even after about almost 10 months, we are still not very sure what is the best. So what we did, we had a lot of our alumni, just like Punjab University. So they were working at different places in the world. So we contacted them. We said, okay, let's have a webinar. So right in the last week of March and first week of April, we asked them, because Australia, Italy, UK, already the number of cases were very high. So we asked them, why don't we have a meeting of 1 to 2 hours? So I remember that the first meeting at the end of March, we had people from USA, and they were very much stressed at that time, because the number of cases were at the peak at that time. The Italy, this is our Dr. Curino, he was there. He had come a couple of weeks before this pandemic. He had visited us. So I just talked to him. He showed his hospital, how they are managing, what are the problems they are facing, and what are the drugs is the best. So people are just guessing and using the drugs, I must say. Even now, a lot of things are experimental. But anyway, we updated ourselves quickly. We not only updated ourselves, we put them into the practice, but also we had webinars subsequently with all our colleagues in Punjab and surrounding areas, so that we provide the upliftment of their knowledge, and they improve their patient care, so that if they are able to take care of patients, they will be able to, they will not be referring those patients to us, and so our workload will decrease. So that was the way we try to update our knowledge before we had even started treating the patients. So as you know, the most of the time the therapy in these patients is supportive, and after our discussion with the various people across the world, it was very clear that unless till now, only thing we have to make sure the patient's oxygenation is taken care of, and if the patient is having any other disease, you take care of that disease. And only one thing which was confirmed, that they need to be anticoagulated. If they are symptomatic, they need to be anticoagulated, because coagulation disturbance was confirmed that they are hypercoagulable, and this may be one of the major reasons for the complications in this patient. And then the different ways of maintaining their oxygenation without putting them on ventilator. Within a couple of days, we could understand putting the patients on ventilator is not the ultimate. We have to make sure that we put them on ventilator at the right time, not to delay too much, not put on them and ventilator at the early period, the way it was being taught to us from the Western literature by the Chinese and the Americans, that the moment he gets hypoxia, just put the patient on intubate and put the patient on ventilator, because if he's breathing fast, if you give some the oxygen treatment with the equipment which is not isolated equipment, and this will contaminate the environment, and you will get more virus. The healthcare worker will get more virus. So one of the reason was just put in a tube, so that and the air remained confined to the machine or to the filters attached to the machine. So anyway, this is how we went ahead. We managed these patients. Even now, you can imagine we have already reached a stage when the number of cases are more than 2 million. Though number of discharges have increased, but the number of deaths is quite high. The testing was another issue which we faced in the beginning. Who are the patients who need to be tested? So initially we were only testing those who are coming from abroad, who had contacts with the infected patients. But later on, any symptoms, patients come with this, fever or running nose, influenza-like symptoms, we used to test. And later on, we are testing even any patient who's admitted to our hospital for any intervention, because if we do not isolate that patient, if you do not detect the infection in that, we may be putting our healthcare workers as well as other hospital patients to the risk. So I think there are three categories of these patients: one, mild, moderate, and severe. And most of the times we suggest that once the patient has mild symptoms, they should be monitored, whether at home or in COVID care centers, and their saturation should be monitored, and their respiratory rate be monitored. And if the respiratory rate goes up, or if the saturation drops, then they are labeled as moderate, and then they have some expert advice need to be, and once they are very sick, they need to be admitted into ICU to take care of these patients. The risk factors for this severity of the disease, as I said, 80% will be asymptomatic or mildly symptomatic, and just precaution of isolation of those patients from the rest of the house or rest of the people is good enough. But these are the patients: old age patient, obese patients, patients having heart disease, diabetics, heart and the lung and kidney disease, or having any cancer. They are the patients who are high risk factors for getting severe disease, and they need to be monitored more closely. So what we started here right in the beginning is, instead of putting that patients on ventilator, we tried best that we use the posture therapy to improve their oxygenation. And most of times we help, this therapy helps, and we are either able to delay the ventilation, artificial ventilation, or maybe avoid the artificial ventilation. So as I said, the ventilators are not panacea, because once you put the patient on ventilators, they are unconscious, you need more manpower to take care of them. And because there's more invasive, the more incidence of infection is there. So what we thought in the beginning was confirmed by rest of the people all over the world, that we should not be doing early intubation and ventilation, but we should not avoid totally ventilation, because that is also not the. We have to devise indicators that we put the patient on ventilator the moment he is really requiring, and for that we have a lot of criteria which I'm not going to discuss here. So there was another steroid controversy while in the last couple of days or weeks, and when we started using in April, there was a lot of objections from the different people, because the ICMR had not allowed it to be used. But our friends in US and UK, they had shown that steroids do help, because this disease is basically not only the virus infects the lungs and cause the damage, but the moment it invades the defensive cells of the body, the defensive cells overreact and produce cytokine storm in the body. And if we, and the most of the damage is done by that cytokine storm. So if you can avoid that storm by giving steroids at the right time, you may be able to minimize the damage. So that was the thing we discussed, and later half of the April we started using steroids after discussing at with various experts in our group as well as outside. So this is how I explained that when the virus comes, attacks the lung, there will be initially some injury to the lung mucosa, the cells, they're attached to the ACE receptors in the lungs. But once the abnormal host immune response occurs, a lot of interleukins are released. So then it causes huge damage to the rest of the body. So by steroids by preventing this, minimizing the symptoms, can lead to improvement in the patient care. So but unnecessary use of steroids at a time when patient is not requiring oxygen can have complications. So the people we have seen nowadays, the people are coming up to the hospitals who started using steroids even when they were not having any hypoxia. So that's not right. Before giving these drugs, taking these drugs, which are sometimes available across the counter from different pharmacies, and they need to be curbed. So and there is the plasma therapy also was tried here and is still being worked on. What we have found at the trials which are going on all over the country, that initial phase of viral response phase, not at the time when the cytokine storm has really taken off and is causing damage. The people have mostly used in the severe stage, but what we found that the best advantage of this is in this stage, in the early stage, when the patient has just started showing the abnormal chest X-ray or the hypoxia has started just developing. That is the time they may benefit maximum. Now we had to deal with the problems of PPE, the patients, our nursing staff, our healthcare workers. They had damage, skin damage because of the PPE. And see, imagine, we thought the virus will get killed with the peak summer, but unfortunately, the peak summer affected our healthcare workers. See, this lady doctor who helped the patient to be taken to the CT scan center for a CT scan, she had to be doffed in emergency situation because she fainted and she was sweating in that summer of May, and was a peak summer, and we had to take care of this lady in addition to the patient also, which she was taking care. Somebody had to just jump into the after putting that protective equipment quickly and help the patient and help this lady also. So, and once these health workers have worked, we needed to make sure that they are properly motivated, so that they go back into the rest of the groups, and they also motivate others. So after they finish their quarantine, we congratulated them, we welcomed them, we talk to them, learn from their whatever this problems they face, so that the future people do not face the same problem. We have to take care of all people who are involved. Now, our lab people who are working in the COVID hospital around the clock, we made sure that they are also recognized. That's very essential. If you want the best of the people, you make sure that the lowest of the person gets proper recognition, so that they can put the best. No one person can run the show. It is a team right from the bottom to the top which is responsible. We completed our 100 days last month, and you celebrated that. We had very good outcome in these patients, and we congratulated all our the health workers who helped us to reach this stage. And that was the best thing. When the patient's getting discharged and is from ICU, that's the best thing for a healthcare worker, that these efforts are being recognized, and the efforts are successful. So in the beginning, every patient who was discharged, we sent back with the a lot of pomp and show, because we wanted that people should not feel that they are isolated. People should not feel that they are untouchables. So, but though when the number has increased now, this sort of, and we are busy with other work, this sort of the things have decreased, but definitely we still enjoy when our patient from ICU after a couple of weeks of intensive management is discharged, and see some of the patients sending back their thankful messages, and that's very encouraging for all the healthcare workers. So while this was going on, we had a lot of other the activities at the PGI. Now the PGI is not only a training, the clinical area. This is a teaching institute. So we had the MD students, we had the DM students. They are coming. They have after MD they have to join the DM course. After DM they have to join the work they have to do. They have to join their job. So some people suggested, why don't we delay the session by another 1 month or 2 months or 3 months? We said, no, we cannot. If fortunately, in the end of May, the government has started opening up, allowing opening up. So I said, okay, we only rescheduled our exams. We took the exams of all the candidates who are appearing MDMS. We made sure that if the examiners cannot come here, we can have online examination. We did not, because if they cannot examine the sheets, the written papers, we scanned those written papers, sent to them, got the evaluated, got the back. So our training branch helped a lot to ensure that before the sessions completed, all the MD, MS exam, the DM exams were completed. This is one of the online examination center in one of the departments, where the two-way, three-way communication allowed the unbiased examination to be completed of these patients, of these students. So we took help. The entrance exam was a big challenge. The entrance was to be held at different parts of the country. We had engaged TCS for our online examination last December. Fortunately, they helped us. We only rescheduled, instead of having 20 cities, made the centers in 40 cities, so that the people don't have to wait, run around for getting the center to the center. We made arrangements so that nobody stops them from getting into the center. We approached the ministry, who issued blanket orders that anybody who is carrying this order and has this slip, entrance slip ticket, they will not be stopped. So we were able to conduct the exam well in time, and we had the center monitor station in Caro Block, who were monitoring all the centers across the country through this mechanism. And it was a very hectic work. Fortunately, we completed. After that, we completed counseling. We had online counseling for 2 times. And at the end, in the last week of July, we had the final personal physical counseling. And the new people have joined. They were put on quarantine for 2 weeks, and we used the Punjab University International Hostel for this purpose. And then when this was going on, everybody wanted we should start the OPD facilities. So we started partially, but we did not go fully, because what we found was there's a lot of risk involved. And so what we found, that teleconsultation, we gave phones to each department, couple of phones. So the patients used to register with the central registration. Their phone numbers were communicated to the departments. Then the department people, the doctors, will ring them up, try to get their investigations with the WhatsApp messages. They try to even have video calling with them, and some so they were able to treat them, the old patients. And if there's some sick patient, they used to call in the emergency and do the management of those patients. And within a couple of weeks of starting this service, our hospital again became quite full. So while everything was going on in the COVID hospital, we have to have the repair and maintenance and see our repair and maintenance staff with all the PPE. And we do not stop it here. the patients are coming, the patient wants the management, the chronic diseases, kidney diseases, liver diseases, heart diseases, we have to manage them. We found the ways how to manage them. We screened them, and if they were positive, we sent them to the COVID care center or to our COVID block. If they were sick, we sent to the COVID block. If they needed surgery, we did the surgery in the COVID block. And we did even started doing a renal transplant. And in one of the cases, we did even heart transplant during this period. So we use this opportunity to innovate. So we made, with the help of IIT Roper, we made this drone to carry on the samples. We made a trolley. We made splitters to use one ventilator or many patients. We made face shields. We made corona care equipment. A lot of things we innovated in this period. We made this remote monitoring system during this period. So the trials are going on for the vaccine. Innovations, people are innovating. The future is that we must have all the data in electronic form so that we can learn from what we have been doing. We need to form, the special hospitals to look after the infectious disease, and not only the infections, but also the comorbid, like patients with kidney disease, patients with heart disease should also be managed in those bigger hospitals, which we think is the solution. Having a small COVID block or 200, 250 bedded is not the solution, because every day when normally we are admitting 200 patients in the PGI and we are seeing thousands of patients, if 5% of them come positive, they will fill up our COVID block quickly. So we need a bigger infectious disease hospital where we can, not only there in the infectious disease can be treated, but also their other comorbid condition can be treated. Thank you very much for giving opportunity. I am sorry for taking so much time, Dr. Deepti. You will excuse me for that.
Definitely, that was wonderful. So I think even if it had gone on for 1 more hour, nobody would have objected. That was wonderful.
Yes, sir. In fact, so many messages are coming where everyone is thanking you. And I'll read out some questions also, sir, before we continue.
Dr. Puri, could you please switch on your camera? People would like to see the commander of the forces.
No.
Please switch on your.
It was really an eye-opening.
Sonia, we should have a round of applause. Yes, you are visible now. Thank you. Sonia, we should have a round of applause for Dr. Puri and his team first.
Ma'am, if we do that, then it will be like, thunderbolts, because all the mics will be on.
Okay. So, Dr. Puri, we salute you.
Thank you, Dr. Deepti, for giving me opportunity.
Wonderful job.
Everyone can switch on their cameras though, and for a minute.
I think we avoid that because the connectivity will suffer. Why don't you just ask the people who want to, get some answers?
Yes, ma'am. I will call out the names. They can ask their questions. I also have some names. First of all, I would. Indurika ma'am has called Corona Pro Sahib, and she is asking a question. Ma'am, would you like to unmute and ask your question? Or should I read it out?
Yeah, read it out.
Okay, she's saying, what instructions to the general public for precautions of corona? Day-to-day activity.
Very good. I think I showed you the one of the slides in the beginning, that we don't know whether it spreads by droplets, whether it spreads by just airborne, whatever may be. One thing is very clear: if you don't gather, if you keep distance, and you keep your face covered, not only you will not spread infection, your chances of getting infection from others is also minimized. So these are the few things: hand hygiene, keeping your self from a distance from other people, and if at all you are going to take care or you're going in more close proximity with patient who or person who is probably maybe suspected, then we must wear N95 mask, tightly fitting N95 mask. Otherwise, simple surgical mask, simple cloth mask is essential, but you must change these masks regularly. You should not just put it, same mask time and again, and try to, when we give instructions to our people, our healthcare worker, that the moment we have provided the washing facilities within the hospital before they leave to their homes. But even when they leave for the home, we tell them, once you go home, you must isolate this yourself. You must change your clothes and wash yourself and then go in. So that is the way we can prevent infection going from the hospital to the to your home.
Thank you,
And
sir.
obviously, a good diet, good rest, and those people who are having chronic conditions like heart, kidney disease, they must keep carrying on doing their taking their medications and keep consulting their doctor, even if on the phone. They must keep in touch, because this is a time we don't want any of these chronic patients to get sick, because to take care of these patients is a big challenge, because you may get exposed when you come to the hospital. And if you are, even if you are not, if you are positive, then you may not get the best of the treatment, because then you will have to be isolated. And I must tell you the truth, that's the fact, that once you are a positive, there is a there is little bit of barrier around you. So all those people who are taking care of, they will have to put on the protective equipment, and that definitely decreases their efficiency a little bit. And it's not that, but if you're not infected, obviously I'll take care of with minimum simple mask, gown, gloves. That will be good enough, and we'll be able to take care of the patients very well.
Thank you, sir. Sir, another question from Mr. Sushant Konar is, sir, what drives you, what motivates you and your team to tackle such complex and life-threatening problems when everyone is trying to save their own lives? Sir, can you hear me? Sir, you have put yourself on mute, I think.
Can you repeat the question, please?
Sir, the question is, what drives you? What motivates you and the team to tackle such a complex, life-threatening problem?
Well, you should be ready to take challenges in this world. When you come, if you are not solving the problem, if you're not facing the challenges, it's just like going through the routines. I don't like, and I think most of the people don't like that. They want to do something which not only challenging but also brings maximum benefit to the maximum people. So that is the, I think, and we at PGI, most of the people are very motivated. They try to do the best, and obviously we teach our healthcare workers, you try to put your best, but not at your cost, which means you must put on your take care of your own health. At the same time, don't avoid taking care of patients just because they are having this particular disease.
Sir, how much time did you get to plan for all this, the precautions and procedures?
In the beginning, if you say how much time it took up for setting up, see, the WhatsApp is a very good media if you want to use it very well. Right in the beginning of end of February and the beginning of March, we were getting messages from our friends what difficulties they were facing, and at the back of our mind, we had already made up our plan. If this is going to happen, we'll do this, we'll this. So different people worked on a different angles. So the moment I came to the bells were ringing that just things are going to bad, then we made our team that somebody was to procure the equipment. We started this work even before the our as a head of the department, even before the director put the responsibility of COVID block on us. As a head of department, I started preparing myself from the 10th of March, and we had stocks of disposables, we had whatever, but that cannot take care of the hospital. That was just that in case desperate needs, my staff member falls sick, if I have to take care of a sick patient, then I must have something with me to take care. So we got ready with that, and then the administration helped, the government helped, and the lockdown helped. We got some time to prepare ourselves, but yes, 1 week we took to mobilize our engineers, mobilize our healthcare workers, train them, and set the ball rolling.
Sir, another question is, what are the few prominent engineering challenges you have encountered during this endemic?
Engineering challenge, one of the thing was the air conditioning. There were different people were talking differently, that we must do this. Some expert will say like this, but nobody had, worked. Fortunately, we had some sort of facility in an advanced cardiac center earlier, but that was very limited facility. 2 rooms had negative pressure. So we thought, why not create the same thing in here? And because we cannot bring the whole machinery, buy the machinery, install, it takes months. So I asked how much time it's going to take. They said at least a month if everything is available. I said then we must go for jugaad. So we talked to the people abroad, we talked to the our own people, and we made this local changes in our system, that what we need is that same air should not go to the healthcare worker or in the area which is where the normal people are going. So make sure that that air doesn't go back to the infected air. So that's basic principle, and make sure that maximum fresh air comes into the working area. And so that we use the filters at whatever place we take. We have like filters in the breathing circuits, filters in the air conditioning, and we put exhaust. We had a fume clearing system installed in the NHE, so which to be used only in case of fire. So what we made, that every hourly they will just switch on that for few minutes, 4 or 5 minutes, and it will suck out all the air, so it replaced with the fresh air from the outside. So that was another thing. The other engineering issue was we had to set up a dialysis place here. This was a new place. Fortunately, there was we had made some arrangements while planning this building, but still it was not made that it will be totally isolated. We need 10 people to be dialyzed simultaneously. So that was an engineering issue, and we had to really convince our engineers, the lower level workers, put on the PPE, go with them, tell them what to do, put on their pipes, connect to the the freshwater system. The biggest challenge now, I just while talking was that when the patients, when our healthcare workers are working in that environment, though the environment we were able to create a temperature of 23 or 24 or 22 degrees centigrade in the ICUs or the critical area, but that was not good for our people who were wearing this double gowns, the mask and other things. So they were feeling hot. They used to say that every time they go there, they are sweating. They are not able to. There's a lot of fogging is there. So we made some alterations. We tried to convince our engineers. We made some shortcuts which would not have done ideally, but then there was no way out. So we sorted out, and because unless the healthcare worker who is going to take care of patient is not comfortable, he will not be able to deliver the best. So these are the air conditioning issues of one major thing, and the second thing was the dialysis unit installation, and of course the rest of things are minor things, putting the CCTV and other things.
Thank you, sir. Sir, one last question before. Okay, there are two, three more, but I'll just because we are running out of time. One person asked, I'm a heart cardiomyopathy patient. Would the symptoms of infection be different from that of a heart problem for me?
Well, see, in general, the symptoms of this disease are having fever, malaise, and if you go little, the severity increases, you may feel breathless. But patients who are having heart problem, who are having diabetes, their vessels are already diseased, their organs are already working borderline. So they may become symptomatic much earlier. So, well, prevention is the best cure. So you need to prevent yourself from getting infected from the people, and till the vaccine is developed, you need not be very courageous to go in the public without any protective equipment on yourself. And of course, take the your medications regularly. Some of the things which we have learned is from our friends in Italy, from their autopsy findings, which they told us in the last week of March. They said that their patients are very hypercoagulable, and we need to give anticoagulants to that. So that is if patients who are taking aspirin, clopidogrel, antiplatelet, they must continue with that. They should not stop even for a day or two without the concurrence of your cardiologist or physician.
Sir, one last question. Before I go to that, ma'am is thanking you for the answer, and she's saying yes, in this season we do go breathless. Next question is air conditioning at home these days advisable, or we should put on only fans?
I should have answered you very clearly. See, any air conditioner where there's recirculation and if there is any infected patient in that room, is going to be danger for the future. So anything where there is recirculation of the air needs to be avoided. So having a fresh air all the time, because but if there is no recirculation, the efficiency of any air conditioning decreases. So best will be, in a very crude way, minimize the use of air conditioners, who are rather stop using the air conditioner where the recirculation of the air. But if you're just cooling the air, taking fresh air from outside, cooling the air and throwing inside, that is fine. But that is not a very efficient way of using the energy. But then that's the way to protect yourself. If you are in a group, I mean, we find people who are sitting in a very close spaces, very congested, and they're using the air conditioning where there's a lot of recirculation. I think people should be careful at that time.
Thank you, sir, for all the answers. There are more comments thanking you for all your efforts, and rather than question, people are saying that they're really impressed and they appreciate by what PGI is doing, and you've really faced a warlike situation. And thank you for sharing the details. Mr. Bedi wishes you all success and effective control against coronavirus. All our participants are thanking you, sir. And I would also like to thank you. I can see that it is time for you also to have a tea. And, and our participants have been really good, and they are giving good messages. And thank you for all the time you have given us. Sir, it is very difficult in your profession to take out time and come and give such lectures, because but you are in a way, making us aware of what we should do, and the way you have planned, we were spellbound. The way you have planned is just like planning for a war, and it was a war. The way the protective gears were put on, how everything was planned, the strategizing, and on top of that, your positive outlook. When you were talking about all the staff gearing up for their rounds, and you said it's like a fashion parade. They're getting ready for that. That's a positive outlook that we can see even in such a stressful situation. You can find humor. And we really thank you for your time, sir. And really humbled that you have taken out time for us. Deepti ma'am, would you like to say something?
Thank you for the kind words.
Thank you, Dr. Puri.
Thank you, Dr. Devi, and thank you all of you. And it's not my work. I think this team is very important, and a team at our PGI is very enthusiastic, very helpful, and very aggressive. And I thank all my team members for the work which they are doing, and we'll continue to do the work, justify our existence in this community. Thank you very much.
Thank you, sir.
Thank you, sir.
You said this also, at this point was very good, that recognition of a person on the lowest rung is also very important in teamwork. So thank you for your time. With your permission, I will end the meeting now.
Thank you. Thank you.
Thank you. Thank you, everyone. Have a wonderful day.
Thank you, Dr.